can see how the heart works, and we can actually look at the back side of it, and we can look at the coronaries. Let's see if I can. These are some of the arteries that we have. The right coronary artery, the main artery on the front side of the heart is called the left anterior descending artery. And then, let me just get one more. We can look at the coronaries themselves, and we see this is the right coronary artery that's on the left side there, and there's the left main. So most of the blood flow to the heart that gives the heart its oxygen and substance is on the left side. And this is the one we see, this artery right here is called the left anterior descending artery. It's also called I forgot what the word was, but it's anyway. That was that's what the coronaries look like, all right? That's the veins in the heart, so we don't need to look at that. I wanted to show you a few of the other things that happen with the heart. So let me just get my glasses on here, and then we'll look at some of the heart attack issues. So this first graphic is a normal coronary artery, and as time goes on, we get fatty buildup plaques, and then that little bit of a little rent in that plaque causes the plaque to develop, or platelets to get together and causes a clot. That's how the heart attacks work. One more here. When we have a heart attack, on the left side, it's normal, and see how the blood vessels, they fill during relaxation and then they squeeze down during contraction. And here is a heart attack. That's where a artery got plugged up, and then you can see how it's not contracting down in that area. So let me just switch over to the atrial fibrillation, because that's the most common arrhythmia, and it has a lot of complications. This is a normal heart here, and you can see that the heart rhythm is very regular, and the sinus node is the node that triggers the atrial contraction, and the AV node then contracts sequentially. So it's a very organized electrical heart that can contract very efficiently. And if you look at the valves, see how they're closing they're open there, close. Over here, look how irregular they are. And so the efficiency of the heart is not very good. Also, the atrial fibrillation starts in these pulmonary veins in the left atrium rather than the SA node. And so you can see that there's just a lot of randomness in this atrial fibrillation. And we'll just have just another one or two of these, and I'll show you. So here's the atrial fibrillation. What it can cause: blood clots, strokes, and heart failure, because the atria don't contract. And so we start to get blood that gets stasis, we call it, in the atrium, and you can see we get a blood clot, can go out, goes up into the brain. So this is about 4 or 5 times an increase for stroke with atrial fibrillation. Women are more prone to it than men, and as we get older, the risks tend to go up. And then up here, especially in Summit County, because of the altitude, the atrial fibrillation gets going a little faster than down at lower altitude sometimes, and it can make the heart get weaker as well. And we do have ways to help that. Let me get this back. So if we need to get rid of the atrial fibrillation where they start, we can put a catheter through the heart, and this is out just through the vein, and we have an ablation which scars that area, and it keeps these areas here from triggering that atrial fibrillation. So that's a very common test that we do for people that have pulmonary hypertension. Atrial fibrillation. So let me just take that. I wanted to show you that. Any questions about that? Because those were some of the diagrams that we can tell you, show what we can deal with to help some of these tests. Let me just take one moment and I'll get you connected here. All right. So this talk is going to be about a lot of risk factors. And anytime, if you have any questions for a small group, just raise your hand and we can talk about it. We looked at some of this there. This is the right ventricle, here's the left, and those atria, which you already saw. But we can also look at them with ultrasound. So this is Beth, our sonographer, and we can get pictures like this. These are different angles of the same patient. So this is, we call a short axis. It's like if the heart's like this, and we put a cross section, you'll see it in a round area. So these two, you can put in your mind if it's a 3-dimensional thing or not. We have the 4 chambers. So the first thing I wanted to talk about was how heart attacks happen. And if you look at most of the heart attacks, there is usually some plaque, or cholesterol plaque. And if you look at this single layer of cell, it's called the intima, and it's real thin, and it permits a lot of the nutrients to go in and out of the blood vessel. And if you see this little area here, this is an area that was damaged either from hypertension or sometimes these start with at a branch point of a blood vessel. And this is the plaque that is usually without a medication like a statin. These oftentimes are active, and so they can be about a degree higher, just in another area. So we can put thermistors in there and can tell if it is active. But that's how we learned that the plaque can rupture in these sites, and that triggers the platelets. The other thing that was really interesting, in World War II, we had a lot of men that died early in their 20s, or even younger, some of them. And we knew then that we had what's called a fatty streak, and that is the beginning of it. So even people that are in their between 13 and 19, there's about 20% of them have some cholesterol deposition. So, you know, we need to be attentive to the young people as well. This continues to grow, and we see that year after year, the prevalence of these sclerotic plaques are almost, you know, at least 80% of us have over, if we're 50 years old. And this is a little better graphic about how a heart attack happens. So as the fatty streak starts happening, it gradually can have a minor plaque, but once we start getting these bigger plaques a lot of heart attacks do not occur with a large plaque. Oftentimes, even the smaller ones can cause this to rupture and then causes the blood clot. So you've all heard about cholesterol and triglycerides. These are the types of lipoprotein classes, is what we call them. The LDL is, now we know that this is the major problem for heart attacks and stroke. And the LDL is the very pro-inflammatory protein. HDL is good cholesterol. That tends to take cholesterol out of the blood vessels, while the LDL is putting it in. So, and then there's triglycerides as well. So these are the optimum levels. Now this is about 10 years old, this slide. So I'm going to modify this a little bit. But triglycerides, we still like to have them less than 150. The total cholesterol, we like it less than 180. The HDL greater than 40. The LDL around 100 or less, without any risk factors. If we have risk factors, we want them less than 100, and just in the last 3 months, the 70 was the target for people that had a heart attack, an angioplasty, a bypass graft, stroke, or diabetes. We wanted it less than 70. The thinking is now it's probably would be ideal down to 50. So that's the cholesterol side of it. We do have some very good medications that we started to have in the 1990s, and that's the statins. And there are people, as you know, who can't tolerate some of the statins. We have different ones that we can try, and now we have one. It's called Praluent, and that is an injectable, either every 2 weeks or once a month, and it's a very expensive drug at this time. But there's many people that can't tolerate statins, and they are at very high risk, some of them. So that medicine will, and that family of medicines will be coming online. They're already now, the FDA has cleared them. If we look at the other risk factors, blood pressure is a very important thing to have, keep an eye on, and it's very silent, of course, and the relative risk of having a heart attack is normal at 115/75. Every 20 millimeters it will double. So if you're at 140, it would be over two times. The relative risk is 4 times with blood pressure at 55 over 95, and some people have pressures over 175, over 105, and it's an 8-fold problem. So I think I'd like to have everybody have a blood pressure at home, because you never know who might need it, especially up here because of the altitude. And last week we were talking about the adrenaline that increases up here because of the hypoxia. So that is a good thing. I think a lot of us like alcohol, I suppose. Anybody? Okay. Well, this is a two-edged sword. Alcohol and all-cause mortality. There was a study that showed men and women and how many drinks you can have. And this is a baseline without any alcohol. And sure enough, it did improve the relative risk of death. But you have to be about 1 drink per day. And this is the women. They have lost almost all of the benefit with after 2 drinks. Men go a little further, but it's just we're larger, and I think that's probably the biggest thing. So if we're going to have a glass of wine, don't do what this guy does. He said, my doctor says one glass of wine a day is good for me, so that's my limit. The risk of death fell 45% between 1980 and 2000, and these were the things that we had stop smoking programs. People that smoke have about a 3-fold increase. Blood pressure control that we talked about. In those days, we did, and we still have today, acute coronary syndromes. These are very active plaques that start to cause a near heart attack. And so when those people are starting to have an increase in their heart rate and their increase in their chest pain, they can get these coronary syndromes that are very, very risky, because if somebody has a change in their angina within a month, they are very likely to have a heart attack. If it's increasing day by day, that's also. So anytime you have, it doesn't have to be intense, the chest pain, but it does need to be, the frequency of it does make a difference. We also had angioplasty and bypass surgery at that time. We had better heart failure treatment and the lipid treatment. We didn't get the statins until 1990. So when we think about what was the main things that caused that rate of coronary deaths to go down, many people thought that it was angioplasty or surgery, but most of it was the lipids, the cholesterol, the blood pressure control, and stopping smoking. So that's the major, even today, that's the most important things that we need to look at. So Michelangelo, this is David, of course, and that's what we ought to look like. When David immigrated to America, something happened, I guess. We do hike occasionally, but the obesity problem is really taking over our country and also other countries. In 1990, there, and if we look down here on the percentages, there was just very few. There was no data in a few of these places or states, but it was about 10 to 15% of the population were obese, and that's a BMI over 30 or about 30 pounds overweight. Just 10 years later, the only state that was lagging behind the obesity was Colorado. And this has progressed even to 2010, and it's going on every year. Even in Colorado, we have about 1% per year increase in the obesity. And that's happening all over the country. So, it's over in these southern states, it's over 30% is people are obese. So we got to get out and get working. That's why the Cheetahs are so good. He can't believe it. So anyway, so that's, but the idea is to be active, be exercising, and eat well. This is just I'm sorry this isn't active, but this is a normal heart. This is a heart failure patient, and you can see how much bigger that is. This is the blood in the blood vessel. This is the heart muscle itself. And I think, how many were here last week? Okay. Yeah, so we talked a little bit about this this heart rate, or I'm sorry, the heart failure. And if just going from sea level to our altitude, it's about 7% lower cardiac output. And if we look at a person that has mild heart failure, that's even more. It's about 15% up here. And if we have somebody that's having heart attack, like that last slide, those individuals can not tolerate this atmosphere as well. So, any questions about cholesterols, any other risk factors? If you think about it, just let me know, okay? We can talk about it. So this is a normal aortic valve right here. And this is the mitral valve. And if we put color flow on it, and we can see where the turbulence is, and you see that yellow area up there? That's a very rapid flowing jet. And so that helps us look at some of these blood vessels, or these the heart problems. In the aortic valve, most of us have 3 cusps. There's 1, 2, 3. About 2% of the population have bicuspid aortic valves. And that's what this looks like. And the thing that is important about that is that these develop leaks, and they start to calcify faster for most people that have the bicuspid valve. And they also can increase the aorta. So the aorta itself is weaker in some of these bicuspid valves. And so the silent thing is the aorta getting bigger and bigger without even knowing it. So that's, if somebody has a bicuspid valve, we certainly want to look with an ultrasound to look at the aorta. This is the bicuspid valve, and this is the tricuspid valve, the normal one. And this is what happens after several years of undergoing a lot of wear and tear. This is the aortic valve. It's calcified, it's not moving, and this one has to be repaired. The mitral valve here is also, this is a normal one, and I'll show you some of the problems with some of these. A rheumatic fever can cause this valve to attach to each other of the leaflet, and so that causes the blood in the atrium to have a more difficult time to get into the ventricle. And here you can see that those colors, that's just a lot of turbulence that happens. Does anybody know about a mitral valve prolapse? Anybody? Great. Okay. So mitral valves can have a prolapse, and you can see how that prolapse up instead of just coming together like that. And so this is called a myxomatous valve, and about 2% of the population have some degree of a leak in their valves. And if you look at that, you can see exactly what's happening, right? This is just with the turbulence that I was going to show you. And how we fix these is we cut out a wedge and we sew it up and to tighten it, so it's not going to be as redundant. And this is the amount of leaflet that they took out and just sewed it up. So this is an infection on a valve. It shouldn't be there. And that one, you can see it with the color flow. You can see where the jet is going. It's going right up here. And this was taken out and replaced. This is another aortic valve vegetation that got on the aortic valve, and you can see that's just, it's obviously leaking, and here you see it over here in that color flow. So this is something that happens up here frequently. This is normal. This is the pulmonary artery, and this is a blood clot, pulmonary embolus. And so, and those can be very silent as well. Some people can die suddenly, or they can get just very short of breath. Another abnormality that's rare, but it's in our practice we had about one of these a year, and this is the myxoma. This is a growth. It's not malignant, but you can see it here. It's attached to the septum. In the two atria right down here. This is a septum between the two, and this plops in and out of the tricuspid valve. And some people pass out with this because it gets stuck in the valve. So the other thing, this is a heart attack, and you can't see it here, but this area here, see how thin it is? And this is the muscle, the good muscle of the ventricle. And it's good. This is what happened. And you see that little thing flopping back and forth? It's a blood clot. You don't want that. That can go out of the heart and go up to the heart or to the brain. Myocardial infarction, it's an old one. It's scarred. This is what happens after several years of a heart attack. And we don't see this as much now because we take people to the cath lab as soon as possible to try to get preserve as much heart muscle as possible. And so that's the reason we try to get to the emergency room and get into the cath lab within about 70 or 90 minutes at the latest if possible. And this is one that actually ruptured between the two chambers. And then this is also one that ruptured right there, and you can see the blood flow from this chamber into this is the left ventricle, to the right ventricle. And you can see that's needs to be repaired. This is we also see this. It's pericardial effusion, and this can happen with infections, viruses, and this one is okay as far as the heart is functioning okay. But over here, you see that right ventricle is here. It's open. Over here, it's kind of rocking back and forth more than this one. And when the pressure increases here, we have the blood flow can't be circulated very well with the heart. So we have to. And here's another. But what we have to do is put a needle into that sac and just draw it out. And I've had patients that I've done that, and they wake up and their cardiac output gets more just enough to keep the heart able to. And then what we do is usually leave a little catheter in there, let it drain, and if it's a virus, that goes away and it doesn't have a problem. But we also take the blood, and because it can be metastasis of cancer that is not unusual to get in that sac. And this is a patient had a stroke and did a ultrasound in the neck on the carotid, and look at these things. They're all little blood clots. Now this, what do you think that is? It's not a worm. So let me just show you. So this is the aorta right here. And I showed you that real thin first layer of the blood vessels. And this is a aortic dissection. And this got torn off. And if we look at it in the other view, there's where it's torn all the way up there. And here's where the rent in that little area is. So that's what, with those people that have enlarged aortas, those can end up like this. So that's why we need to keep a close eye on some of those. I have several patients that we follow every 6 months or every year up here, depending upon how big it is and if it's changing or not. So those are just a few kind of interesting things. I think that we have a very good sonographer. Beth is great. She's very impulsive, and we can identify many of these things up here, and then if we need to get them fixed, they can go down to Denver quickly. So, any questions about any of this? Okay, well, great. Thanks for coming, and we'll see if we have any other interesting things some other time. So, thanks for coming. Oh, we have this.
You have a raffle.
Yes. Oh, yeah. I'm the raffle.
You get to pick
picker.
the tickets, and I'll give out the goodies.
All right. Excellent.
Yeah.
There you go. I'll need my glasses. Okay. 448307.
Allison, that's you.
Thanks.
That's weird.
There's more. more. There's 4 more.
Yeah. Here we go. 448, 403. No?
No? Must be left over.
All right. 448.